So hello everyone, my name is Peng Ren. I'm coming from Fudan University and ISTBI from China. So exciting to meet so many interesting presentations these days. And today I want to share you a piece of work about synergic, cholinergic, and dopaminergic role in motor symptoms of sporadic Parkinson's disease. As I have just stepped into this kind of field, so I'm open to any valuable suggestions. Okay. So as early as 2003, Brick found that the loss of neurons in substantia nigra of early PD occurs almost simultaneously with the deposition of synuclein in the basal forebrain tissue, and specifically its nucleus basalis of Meynert. This reveals a potential joint role of cholinergic and dopaminergic role in Parkinson's disease. After which, Schwartz found that the volume of NBM and its diffusion rate can predict the occurrence of cognitive impairment in Parkinson's disease. Moreover, Barrett revealed that the integrity of NBM can also be associated with the psychiatric symptom and autonomic symptoms in Parkinson's disease. And moreover, Nicolay recently demonstrated that the integration of the NBM can predict the cognitive impairment, while the integrity of the PPMI nuclei in the, I think it's brainstem, and it can predict the cognitive flexibility. So that means regions related to cholinergic system are not only associated with cognition in PD, but also with other non-motor symptoms. And interestingly, a recent work has revealed the motor symptoms that's related to cholinergic system, including the gait problem, freezing of gait, and also falls. And the recent work revealed that the integrity of NBM can predict the progression of a gait problem, and the integrity of PPM can also predict the progression of posture instability and gait disorders. So that means regions related to cholinergic system were not only included in non-motor symptom, but also included in motor symptom. However, apart from the NBM role in the posture instability and gait problem, the less is known about how the cholinergic system is involved in other motor symptoms. And also, since the cholinergic system is involved in both motor and non-motor symptoms, so little is also known about how whether the cholinergic system in motor symptoms will be influenced by the existence of non-motor symptoms. To try to answer these two questions, we're utilizing the dataset from Parkinson's Progression Markers Initiative. We simultaneously investigated the role of cholinergic and dopaminergic systems in Parkinson's motor symptom with both cross-sectional and longitudinal perspective. So to begin with, we selected participants with at least 2 time points with baseline and another one with low quality image, and those patients with incomplete information excluded, and the gray matter volume and the dopamine transporter concentrations and also T1, T2 ratios are calculated for healthy controls and Parkinson's disease patients. And the motor and non-motor symptoms are characterized by the corresponding clinical scales. So we further divide PD patients into the never and any group according to whether there's consistent non-motor symptoms across different longitudinal visits. So in parallel with previous publication, according to the definition of dopamine cholinergic system, we selected basal forebrain nucleus basalis of Meynert, and also medial set group, and also its pedunculopatine nuclei. As for dopaminergic system, we focused on substantia nigra and ventral rectangle area, as well as dopamine innervative regions, including putamen, caudate, and globus pallidus. So basically, at baseline, consistent with the previous well-known effect, PD patients showed significantly lower dopamine transporter concentration on PET and also worse motor symptom. Also, compared with controls, PD patients showed faster progression of motor symptoms, various motor symptoms, and also the faster degeneration of volume of caudate. After separate characterization of the motor symptoms and the regions related to the two transmitter systems, let's now turn to the association between them. As seen in this heat map, we can see that the T1, T2 ratio of cholinergic PPN nuclei and also various dopamine RIs, they are longitudinally associated with the change in various motor symptoms. And the same is true for the dopamine transporter concentrations of putamen and caudate. Besides, the gray volume of putamen and caudate also show some longitudinal associations. Well, however, no significant neuroimage markers were found for the progression of tremor. And overall, in this slide, we found that the progression of various motor symptoms are more extensively associated with the dopaminergic regions. Yeah. So following this, a more interesting question will be, will the regions that are associated with the progression of the motor symptoms have the effect of predicting future progression? So we noticed a relatively different picture here. As can be seen here, apart from the NBM prediction of PIGD, we found that the T1, T2 ratio of NBM can also be predictive of the bradykinesia and overall motor symptoms. And this is not reported in previous publications. Since we found multiple predictors for PIGD, we would like to compare the contribution of different measures by leveraging a stepwise strategy for the longitudinal prediction. And we found that the NBM and caudate measures both play an important role in predicting the progression of motor symptoms. And if we want to talk about this method, we can talk it later. So as we mentioned earlier, since the cholinergic system is involved in both motor and non-motor symptoms, we wonder whether the discovered effects above are influenced by the existence of non-motor symptoms. So basically, at baseline, only lower dopamine transporter concentrations were found in the any group that with consistent non-motor symptoms across the visits than the never group. Well, no other difference were found between these two subgroups. So when we focused on the longitudinal association of these two subgroups, we found that any group repeated most of the results from the entire PD group that we observed above. And for the never group, although some associations were found, the statistical power was much lower. So when it comes to the longitudinal prediction, you may have noticed that the any group repeated most of the results from the above PD, the entire PD group. And the regions that related to the two transmitter symptoms cannot predict the progression of motor symptoms in the never group. And also something different from the entire PD group is that the T1, T2 ratio, MSDB, and caudate can also predict the progression of bradykinesia and the overall motor symptoms. So since there are multiple predictors also similar as above for these two motor symptoms, we also use the previously mentioned stepwise method. And we found that the NBM and caudate both play important role for prediction. Specifically, it's the T1 T2 ratio of NBM and also whatever measures T1 T2 ratio or volume or dopamine transporter concentration of caudate. They both play important role for prediction. And for validation, since the any group have almost double number of patients and for the neuro group, so to rule out the possibility that the difference we observe above are purely due to the different cohort size, so we implemented a non-model here to try to exclude this, and we found that the difference between subgroups were not due to the sample size. And so we hear that, see here that the true effect size is much larger than the randomized one. Yeah. So we get two summaries. So first, the dopaminergic role can not only serve as an imaging markers for the progression of motor symptoms, but also as a predictive factor for disease progression, while the cholinergic system mainly function as a predictive factor. And the second one, the predictive factor of cholinergic motor symptoms is influenced by the presence of non-motor symptoms. So finally, I'd like to thank all my collaborators for the professional and generous help, including Jianwen Chen and Wei Chen from Funan University, and also Xia Liang. A special thanks to her and from Harbin Institute of Technology. Okay, thank you all for listening.